So our next talk is by Wang from University of Science and Technology of China. It's network localization of gray matter atrophy in addiction. Thank you.
Thank you. Good afternoon. Today I'm so excited to stand here, and now I feel a bit nervous, but everything is okay. I will continue my presentation. Okay. Today I want to talk about the network localization of gray matter atrophy in addictions. First, I have no disclosures. The addictions is a public health concern around the world, as it has been conceptualized as a brain disease. There are numerous frameworks that summarize the symptom brain regions correspondence patterns, showing the diagnosis specific and transdiagnosis effect. The left figure is an illustration to describe the structural atrophy in the addictions. We often see the basal ganglia and the prefrontal cortex showing the addiction involving the reward processing and cognitive control. Also, there are highly similarity between the human study and animal models. So for the addictions, we seem to have a uniform framework to describe the neuromechanism. But recently, meta-analyses report some differences. We can look at the right figures. On average, only 3 studies showing the consistent same structural damage, which maybe suggests that the group level results do not equal to the subject level. So the former is more likely reflect a mean effect of the disease, but the other one is more likely maybe the key factor to helping us to quantify the individual specific effect, and we can apply them to the treatment. In these studies, we want to go one step based on this meta-analysis. Based on this meta-analysis and do some analysis at the individual level. We first take 2 questions. First, is there a common structural atrophy across the patient with the addiction, and how do we measure it? Second question is, if the heterogeneities exist at the structural level, can we explain those heterogeneities? Answer the first questions, we maybe require some individual specific analysis protocol. But as we know, the patients with addictions do not have the grossly observable lesion in the brain structure. So here we maybe need to use some mathematical model to quantify. Here we use the normative models. This approach can estimate the center of the variations like the gray matter volume based on individuals' demographic informations. In other words, this is an individual-specific analysis. We can measure the deviation score for each patient. Then, for the second questions, we use the atrophy network mapping approach. That approach combines the structural and the functional data using the human connectome. It can test whether the regions that functionally connect to the structural atrophy map into a common network. Okay. So specifically, we first collect the participant for the 2 parts. The first part is functionally data. We collect about 333 patients with the 3 subtype addiction. Also, we also collect about the Sheldon's health control MR data. Those parts of data was used to do the normative model analysis at the structural level. And the second part is the resting state fMRI data. We also use for the resting state data, they consist of the 2 parts, the open data set and the local data. And for the second part data is the resting state fMRI data. We also collect from the open data set GSP1 Sheldon's resting state fMRI data. Okay. For the specific method, we first do a OHBM analysis to segment the T1 image into the gray matter volume for all subjects. Then we divide the health control and the patients with addiction into the training data set and the test data set Then for the training data set, we first use it, feed it into the normative model. We use the hierarchical Bayesian regression to predict the individual gray matter volume based on their age, sex, and other demographic informations. After finish the model fitting, we use the test data set to compare with the population's norm and generate the deviation map across the brain. Then we set a threshold of -2 to find significant atrophy in each patient. The -2 reflect the deviations below the two standard deviation, less than the two standard deviations below the mean effect. And finally, we calculate the overlap rate between those atrophy Z-map to measure the heterogeneity. Sorry. Next, we ask if the heterogeneity exists at the structural level. Can we explain that in other perspective? Here we use atrophy network mapping approach. First, we binalyze those atrophy Z-map for each patient's data. Then we perform a functional connectivity based on GSP1 cell dense open data set. For each patient's atrophy seed, it will generate about the cell dense ZFC map. Then we use a t-test with the FW corrections to find significant connection with the structural atrophy. And finally, we also calculate those FC t-map, calculate the overlap rate. And the result should, first we should here is the demographic information and the parameter of the model fittings. We can see the, first see the left figure show the age distribution for the all subject. We can see the healthy controls age distribution is between the 80 to the 70s, which fully cover the patient's group. And the left figure show the 4 parameters of the normative model fittings. And those parameters show the whole brain gray matter volume can be successfully predicted by the age, sex, and the TIV and other informations. Sorry. Sorry. Okay. So for the structural level result, we can say, regardless of the drug type, only 10% to the 20% patients showed consistent atrophy at the same locations. Also, so the last result first showed that the heterogeneity is regionally, the structural atrophy is regionally heterogeneous at the individual level. So by contrast, we also do a traditional statistical analysis using the t-test, and we found that the group level result, there are significant reductions in the basal ganglia and the orbitofrontal lobe, which was consistent with the previous group level findings. And those results identify our first hypothesis that group level findings do not equal to the subject level, and the structural atrophy for across the patient with addictions are regionally heterogeneous. Okay. Next, we ask, can we explain the structural atrophy, the heterogeneities into a common network? The results should here. First, we should the atrophy structure about more than 60 patients can functionally embedded into a homogeneous network. This network is more likely to a default mode network involving the media prefrontal posterior cingulate cortex. And when we divide the patient's data into the 3 subtypes, we also identify this robustness of the brain pattern. Okay, so in our studies, we totally proposed 3 points. The first point is the patient-specific deviations are regionally heterogeneous. This heterogeneous is a general feature of the addiction. In our study, we first found that about only 10 to the 20% patients showed consistent atrophy in the same locations. And how do we expand those heterogeneities here? The second point is the deviations embedded into a common circuit and a network. And we maybe there is a question is which is more important for the patients with addiction? Is there the lesion itself or the remote functionally coupled regions? Here, our question, our answer is the latter. We found this coupled regions can be mapped into a common network. It's more likely to a default mode network. So in our future work, we maybe need to consider which role does the DMN play in the addiction and in this process. And third, generic and preferential targeting of the neural circuit. For this point, we maybe think it may be more effective to consider the treatment of addiction based on the neural circuit and network. Okay. Okay. Sorry. Okay.
Oh, yeah. Oh.
Okay. And finally, I would like to thank my supervisor and funding support, and thank you for your attention. Thank you.
Thank you so much. We only have time for one question, so do we have any questions in the audience? Perfect.
Hi. I think I missed it, but were there separable regions that shows different levels of atrophy, or was the network almost the same, but the level of the atrophy were different among the group?
Sorry.
So you said you could dissociate the atrophy distribution among those patient groups, right? Were there from this similar network, or would you able to find the separable regions that were specifically being decreased in the size in addiction versus or cocaine versus nicotine or alcohol?
Yeah. In our studies, first we just found the structural atrophy, and we did not find the increased the gray matter volume. Here, we through the structural atrophy to find some network patterns, just like default mode network in the functional level. But in the structural level, we can see in the individual level, there are structural atrophy also showing the prefrontal cortex, but we didn't find any stable brain patterns.
Okay. Thank you. Yeah, we have to move on.
Okay. Thanks.
Thank you. Thank you, Min.